this disease takes over someone's brain, right? And who we are comes from our brains, right? The biological substrate in our brain in ways that we really don't understand, whether it's chemical or structural. It's all it's all there, right? So personality, behavior, mood, anxiety, all of those different constructs that we understand are changed by an illness that's causing a disruption in brain circuits, in brain cell function. It causes brain cell death, and it attacks different parts of the brain in different people at different times.
Welcome to Let's Talk Alzheimer's, your place to go for the most up-to-date conversations with world-renowned research scientists and doctors. And now, Let's Talk Alzheimer's with your host, Nancy Keach.
Welcome to Let's Talk Alzheimer's, a podcast from BrightFocus Foundation's Alzheimer's Disease Research Program. Today's episode focuses on the heartbreaking, exhausting, frustrating toll of agitation in Alzheimer's. Agitation can take many forms, from restless pacing, sundowning, repeating the same question over and over, all the way in the extreme to screaming at caregivers and loved ones, refusing to take showers, and ultimately sometimes even to being violent. We're going to try to answer today what the triggers and causes of agitation are and to learn about what can help alleviate it. I hope you enjoy this great interview with Dr. Brent Forester. He is psychiatrist in chief and chairman of psychiatry at Tufts Medical Center. He has spent nearly 3 decades as a geriatric psychiatrist, most recently leading the geriatric psychiatry division at McLean Hospital. And in my opinion, he is one of the best communicators about agitation and dementia around today. Here's our conversation. Really delighted to have you.
It's a pleasure to be here, Nancy, and everyone.
So there's a wide spectrum of behavioral and psychological symptoms or neuropsychiatric symptoms that people describe when that accompany Alzheimer's related dementia. There's wandering and sundowning, anxiety, confusion, aggressive behavior, delirium, hallucinations. So my first question to set the stage is, how is Alzheimer's agitation defined? How do you discern what we call agitation from other neuropsychiatric symptoms?
I've been in this field for about 3 decades, and my passion, for whatever reason, has turned out to be exactly this topic. And one of the reasons I was drawn to this is because Alzheimer's disease and related dementias is not a disease that impacts the individual with the illness. It really is a family disease. And there's nothing more disabling about this illness than these behavioral and psychological symptoms. These symptoms represent a whole range that are of symptoms that are common over the course of this illness. It could be early stages of apathy, which is lack of motivation, and anxiety and depression, or as the disease progresses, agitation, aggression, paranoia, hallucinations. But I think most importantly is that when you, as a care partner, have a loved one with any of these symptoms, you try to do the best you can in describing what it is that you're observing. So, for example, agitation, what is that? It's been broken down into 2 types. There's the verbal type and there's the physical type. It could be yelling and screaming, or it could be pacing and wandering, or hitting or biting, and then there's probably a continuum where it moves into what's more aggression. And so this agitation, aggression exists a bit on a continuum. And we actually have rating scales that can allow us to define the prevalence and the severity of these symptoms. So we can actually measure whatever the intervention is going to be to see if it's effective.
The next question I was going to ask you was, can agitation be measured? You answered it for me. It can be measured. Do you only use those measurements when you're, say, running a clinical trial, or are you to see if something is efficacious, or would there be a reason to try to measure someone's agitation just broadly?
I would say, as a clinician, because I spent a decade to 12 years of my career only taking care of patients and teaching, research then grew on me and I started doing a lot of it, as we'll talk more about. And now I do both. And my main clinical practice is in the assisted living memory care world, where I see a lot of people who have now in moderate and advanced stages of illness where families really can't manage their care anymore and they're getting holistic expert care and treatment. But one of the things that I have noticed since I've done both clinical work and research is that the research instruments that allow us to objectively measure agitation, like the very simple 4-item Pittsburgh Agitation Scale, or the Neuropsychiatric Inventory, or the Cohen-Mansfield Agitation Inventory. Those are 3 that we commonly use. They're wonderful instruments in research to measure severity of symptoms and to track improvement over time, or worsening for that matter. But they're very hard to employ in clinical practice. I would love us to find a way to take some of the measures that we have and find a way to collect this data, if you will, in a remote sort of fashion. Because if I, in a clinical practice setting, ask a nurse or a family member to fill this out every time I see somebody, that's very much one point in time. And these symptoms wax and wane over time, they fluctuate. They happen in the morning or late in the day or at night, or maybe they're gone for 3 days, then they're back again. It's a moving target. And so it becomes very hard to use like a one point in time measure or someone's recollection of the past week or two to really do a thorough job of assessment. But I think that's where the field is going to go, whether it's through wearable devices or other ways to sort of track and collect this information in real time. That will help us so much more in understanding how effective our behavioral and our pharmacological interventions are.
Joseph from Holly Ridge, North Carolina wrote in, what is the percentage of Alzheimer's patients who develop agitation? And Terry wrote, is agitation inevitable for the person with AD? So if you're diagnosed with Alzheimer's, are you definitely going to become agitated? And what percentage of people end up with this?
So if you put all of those vast array of symptoms we first talked about that are agitation plus depression or paranoia or hallucinations, if you add all of those together over the course of this illness, it is way more likely than not. Well over 90% of people with dementia at some point during the illness will have one or more of those symptoms. Agitation itself is probably in the 40 to 60% range in terms of prevalence over the course of the illness, depending on what study you look at. And and so, but that number is not as helpful as understanding what may precipitate it and what may prevent it from happening. But it's, I would say, somewhere between 40 and 60%, depending on the studies you look at.
Is agitation associated with any particular stage of Alzheimer's? And a lot of people ask this question.
I think we clinically we see this and research would bear it out as well, that as people progress from very mild to more in the moderate stage where people start having more difficulty with not just their independent activities of daily living like driving and paying the bills, but also some ability to care for oneself, that's when we start seeing a much greater prevalence of agitation. Less so in the very early mild stages, but it really can occur at any stage. But I think of agitation being more common and frankly more severe as the illness progresses in the moderate and more advanced stages.
And is agitation different in different types of dementias?
The way I think about this is that each one of those types of dementias have certain psychiatric symptoms that are more or less common and are likely related to where in the brain the changes are happening, where the death of brain cells are occurring or disruption in brain pathways are occurring, and the type of illness it is. So I'll give you an example. In the Lewy body type of dementia, we often will see patients, individuals with dementia of the Lewy body type, who not only have symptoms that look like Parkinson's disease, like tremor and difficulty with shuffling gait and prone to falling and reduced facial expression, but also will develop these visual hallucinations that are described often as animals outside the window or babies on the couch, or very clearly describing things that the person is seeing. And interestingly enough, those hallucinations are not always associated with worry or agitation in the person who are describing them. Sometimes they're described just matter of factly, but those hallucinations are common in Lewy body dementia. They can happen in other forms of dementia. Whereas agitation is common in all dementias. And I think in Lewy bodies, sometimes it's related to the hallucinations. In Alzheimer's disease, it may be related to the brain changes that are happening in certain parts of the brain, or we'll talk more about cause. I don't think of agitation as being specific to one form of dementia or another. But what's most important is really trying to understand what is causing it in the moment. And that really is the key to figuring out how best to prevent it and to treat it.
Well, you've brought me beautifully into the next question. Can Vivian wrote, sorry, can a urinary tract infection, UTI, cause behavior changes? And the overarching question I wanted to ask was, what are the triggers? What are the triggers and causes?
Agitation, seeing things that aren't there, irritability, and confusion are really, really common in people who develop urine infections. They're frankly really common in people who are older with dementia who develop any kind of medical problem. The way I think about agitation as a symptom is to try to figure out what's driving that symptom. So whether it's yelling and screaming or irritability or sort of biting people or, or wandering or pacing, I think about it being caused by like three buckets of problems. Okay. One is what's going on in the environment. So you know that if you've got a loved one with dementia who is repeating themselves over and over again, and you're getting frustrated, and you may be getting the same questions 5 times an hour, much less 5 times a day. And you may get irritated yourself. And so the way in which you speak with your loved one with dementia may actually trigger them and they get sort of cranky and irritable with you. So that's an environmental trigger, right? The time of day could be an environmental trigger. As the sun goes down, our circadian rhythms are impacted and it's more likely that the agitation is going to come on late day, early evening as the light changes. Or if you're in a long-term care facility and there's a change of shift and there's a lot of commotion and noise, or if you change to it, you go from home to a hospital because you've got a delirium. All of these things can trigger agitation. And so when we come up with a plan for treatment, we have to take all of these into effect. So that's one bucket is what's going on around the person. The second bucket are medical causes. So urine infections happen to be just really common in older people, women and men, but especially in women. So I don't know if there's something really special about a urine infection that goes direct to your brain and causes these changes. I've never understood that. Honestly, I've never talked to anyone who truly understands that because it could be any infection. When the pandemic hit, we saw a lot of older adults with dementia develop confusion and delirium and agitation as their first symptom of an infection before they had a fever and a cough. So any infection can do this. Change in blood sugar can do this. Low oxygen from emphysema could do this. Heart disease that's not stable can do this. Really important, though, is to be aware of changes in medication. Older adults are very, very sensitive to medications. Side effects of medications can cause agitation. If you've been on a medicine for 5, 10 years at the same dose and now you have agitation, it's probably not that stable dose of medication. But if it's been a change in the last week or two, or the dose was increased, that's something that the doctor should be aware of. And then there's the over the counter stuff that people take all the time. A lot of people take Tylenol PM as an example, as an over the counter medication to help them sleep at night, which 1 or 2 doses is probably fine. But as your brain ages, but especially with dementia, you're sensitive to the anticholinergic effects of the Benadryl that's in the Tylenol PM, and that can cause agitation and confusion and delirium. So the list goes on and on. Constipation, pain, sleep deprivation, all of these things can cause agitation. And then the third bucket. The third bucket is some of our loved ones and our patients, our family members, have a history of psychiatric problems earlier in life. They've had recurrent depression since their 30s, so they've had mania before, they've had psychosis, and now they're older with dementia. They can still have a recurrent episode. So the agitation could be the sign of a recurrent episode of a psychiatric problem. That's not a new problem, it's just coming back again in the setting of dementia. And sometimes a person with a pre existing psychiatric illness who now has agitation and confusion, it could be a recurrence of their previous illness. It could be a new medical problem. It could be what's going on in the environment. And very often, it could be all three, which is why the comprehensive assessment of the cause is really the key thing to finding out the right treatment. The last thing I'll say is the fourth bucket, if you will, would be what exactly is going on in the brain with someone with dementia? Even when they don't have a urine infection or they're not on a new medication causing a side effect. And what's going on is in Alzheimer's disease, as an example, there's a buildup of amyloid plaque and neurofibrillary tau tangles. And these Abnormal protein deposits are causing an inflammatory response, and they're causing eventually death of brain cells and disruption in the different pathways in the brain where the different parts of the brain talk to one another. And neurotransmitters are changing. And all of these brain changes due to the dementia can also elicit the signs of agitation.
So let's start to talk about management strategies and people's experiences. Judy from Emory, Texas, wrote in, can you talk about how keeping things consistent, sleep, calm, and quiet might help reduce agitation and irritability in Alzheimer's? We've seen those three make a real difference in lowering reactivity. So I'm curious if the research lines up with that.
So, the non pharmacological interventions, the rule is this is what we do first, right? We always think about prior to medication, what can we do about someone's environment or the way they're leading their life, their lifestyle? What types of interventions in that domain can help? And even if we do wind up intervening with medications or other treatments, those non pharmacological interventions should be the rule for everyone. So, sleep is so important because when people are sleep deprived, their brains are more sensitive to changes that are going on around them. They're more sensitive to pain and to noise and the effects of anxiety. So, agitation is more common in people who are sleep deprived. So, assuring effective sleep and excluding and treating, if it's discovered, sleep disorders that can be impacting sleep, like obstructive sleep apnea, restless leg syndrome, all of that is really important. A regular diet is critical. We know that there are some amazing studies that have looked at the beneficial effects of different kinds of dietary interventions on healthy brain aging. Not only may it help cognition and function, but we know it helps mood and behavior too. So, principles of the Mediterranean diet, the mind diet, those types of things can really be effective, not just for cognition and function, but also for these behavioral symptoms like agitation. I think exercise may be one of the best studied interventions for healthy brain aging. And not only may it help with reducing inflammation and reducing some of the bad consequences of oxidative stress in the brain that can damage brain cells, but it really does reduce stress. If you exercise regularly, you feel better. You just feel better. The exercise doesn't have to be training for a marathon. It could be walking. And if you can't walk, it could be a stationary bike. Engaging the body in that way helps the mind in so many ways. And then the other thing in terms of sort of the basics is distracting someone from whatever they're worried or focused on that may be triggering or causing the agitation and trying to know. And again, this is where it can't be prescriptive, like this one thing works for all. That never works. It really has to be very individualized. But what does the person love to do? What normally keeps them calm? Is it talking about the past? Is it listening to music? Is it going to walks? Is it a pet? Some people are deathly afraid of dogs. Others love dogs and get calm around dogs. So you have to know for the person who is experiencing the agitation, what is it that helps keep them calm? So all of that is really important. I'm involved with a group that's actually doing a review of the literally thousands of studies that have been done in this area. And I just saw the summary of some of the analyses that are being done. And the bottom line is that despite all of this research, there is no one golden, you know, rule here or one magic bullet. It really is holistic and comprehensive and individualized. But some areas do seem to have more evidence. For example, music. There's a lot of research on the impact, beneficial impact of music therapy, if you will, for people with agitation. That does seem to help. I think the bottom line here is being very individualized, being creative as to the solution, to make sure that you understand the environmental circumstances that might be triggering, to use some of the basics of healthy brain aging, like we talked about with nutrition, sleep, exercise, etc. And no matter what we do with medicines, all of those non-pharmacological interventions need to be utilized.
I'm going to throw some other things at you that people wrote in about and then go to the medicines. CBD and cannabinoids, pulsed electromagnetic field therapy. Robert from Oroville, California wrote, does 800 milligrams of curcumin with black pepper daily and or 40 hertz light and sound therapy reduce agitation? So a bunch of questions about other types of non-drug interventions. Although I guess you could call CBD a drug, but
Yeah, CBD and any cannabinoid is a drug, and curcumin and other products like that are often categorized as nutraceuticals or vitamins, but nutraceuticals essentially that are not FDA approved for anything you can buy over the counter. So let me just take them one at a time, and then the third I would bucket into something called neuromodulation. So for CBD and THC, so cannabinoids, I have been involved in working with cannabinoids in research for about 20 years. So the potential benefit of cannabinoids for agitation, as an example, are biologically that they do seem to help with the neurotransmitters that we know are need to be modulated to reduce anxiety and agitation and elevate mood. So we know that there's a neurotransmitter effect of these cannabinoids. We also know that they may have other more basic biological effects that could be helpful for a brain that's suffering from the symptoms and the disease of Alzheimer's or other dementias. And what it's doing biologically is reducing inflammation. That's always a good thing, usually always a good thing. It helps to promote blood flow. Cannabinoids may help to reduce the damaging effects of what we call oxidative stress from these free radicals in the brain that are basically damaging brain cells. There's a lot of biological, plausible reasons why cannabinoids may be helpful. The problem is whether it's CBD, which is a type of cannabinoid called cannabidiol, or whether it's THC, which is the active ingredient in marijuana, which is tetrahydrocannabidiol. Now, in most states, they're available as medicinal therapies, and you can get a prescription to get them. And in many states, they're available in dispensaries for anyone to go walk in and get them. And the biggest problem is that they're completely understudied. We don't know enough about their drug interactions. We don't know enough about their side effect profile. We really don't know enough about how effective they are for agitation. But most importantly, there are other compounds when you go into a dispensary in what you're buying beyond the THC or CBD. There are other types of cannabinoids that have other effects that are completely unknown. So that's cannabinoids, okay? The curcumin, we could go on and on with the number of nutraceuticals that have been looked at, studied, people have wondered about for agitation or for enhancing cognition and function in people with dementia. Curcumin, omega-3 fatty acids, nicotinamide riboside, we just finished a study on. That's a vitamin B3 compound, and the list goes on and on and on. And all I would say with this is that the last time I saw any kind of report from a federal agency about this was about a decade ago. And nobody really felt that at the time there was any definitive proof to suggest one over the other. And a lot of companies are marketing this heavily for mostly for overall brain function, not for agitation in particular. So could it work? Maybe. Most importantly to know is that these nutraceuticals, even though they don't require prescription, aren't always without side effects. And they often have drug interactions that you need to worry about.
so but let's talk about what has been shown to work and some of the medications. I know that there are some that were previously approved, and then one that was just approved in August. Can you talk about the different types of approved medications?
So I'll talk about the two that are approved, but just for context, for decades, well, again, my career, 30 plus years. So I've been involved in treating these types of problems for 30 years. And up until a few years ago, every single medication that I prescribed for agitation in Alzheimer's, or for depression in Alzheimer's, or for psychosis in Lewy body dementia, all of it was what I would call off label treatment, meaning the FDA never put their stamp of approval like this works and it's safe. Okay. And there was nothing wrong with that, but families needed to know that we were repurposing a medicine with limited information and no stamp of approval from the FDA for symptoms that were debilitating. And so the largest, I would say the class that's gotten the most attention, both for good and for bad, are the antipsychotic medications. These medications have been around since 1954 when chlorpromazine or thorazine was invented, which, by the way, really revolutionized the treatment of schizophrenia and other psychiatric conditions. Those older antipsychotics caused a lot of side effects like Parkinsonism and a movement disorder called tardive dyskinesia, and could make people dizzy with standing and all sorts of side effects. But they calm people down. They also were overutilized, and it led to a lot of federal regulations around the use of the entire class, in long-term care nursing home settings, not in my outpatient clinic, not in your assisted memory care facility, but in nursing homes, starting in 1987. And those guidelines kept getting updated and updated. And I think they're important because they make clinicians take a step back and do the full assessment we just talked about before using them. It doesn't mean you can't use them, you just have to do the assessment. And then every 4 months or 6 months or whatever the regulation is at the time, you have to justify why they're still needed. So we put into place a lot of regulation in nursing homes only, by the way, to make sure these were not overprescribed because the side effects can be problematic. The newer generation, although it's amazing to think they're newer generation, the atypical antipsychotics also work on dopamine, but are generally safer from a movement disorder standpoint, like less Parkinsonism. Those medicines started to become available in the 90s with risperidone. Clozapine was the first in 1988, but risperidone or Risperdal, olanzapine, Zyprexa, or quetiapine, Seroquel, those three are the most commonly used. And another one, aripiprazole, all were well studied. They were well studied in the 90s and early 2000s for agitation and dementia, for psychosis and dementia. But none of them ever got approval, and the reason they didn't get approved was not because they didn't work. They didn't get approved because of safety concerns, and the safety concerns included a risk for stroke and a risk for mortality. The FDA did a meta-analysis in 2005, and they found that in people on antipsychotics with dementia for agitation versus people with dementia and agitation not on antipsychotics, there's a higher death rate over a period of a relatively short period of time in these trials of 6 to 12 weeks. That led to what we called a boxed warning. So if you were to look up any of the medicines I just mentioned, olanzapine, you would see, in the internet, it would a big box saying, "Warning, don't use this unless you've tried other things because it might cause mortality." The relative risk of death is small, but in the sample they looked at, which was pooling data from 17 studies, it was statistically significant. So every time that I've prescribed over the decades one of those medicines, I tell families, it may really help mom calm down. It may improve quality of life. And you also need to know there's a slightly increased risk of death. And this is the risk. And I've never had a family member say, don't prescribe it because of that risk of death. Because the relative risks and benefits at that point, when you've got psychosis with agitation, you're like, we need something now, right? Okay. That warning that came out in 2005, unfortunately, it almost stopped completely research in this area for 20 years. It's a real problem, almost 20 years. The first medication to get an approval for agitation and Alzheimer's in 2023 was brexpiprazole, which is an antipsychotic medication. And it wasn't because brexpiprazole was more effective than olanzapine or quetiapine. They weren't studied head to head. We don't know if it's more or less effective, but it was effective, just like those drugs were effective. And we don't really know if it has the same mortality risk or stroke risk because no one drug and no one study ever showed it. It was just pooling it together with all this data. But the company who developed brexpiprazole decided to study it in Alzheimer's disease with agitation, and they showed that the drug was safe and effective, and it was approved by the FDA. And then, as you were just mentioning, the second drug for agitation and dementia was just approved this past spring. And the exciting thing with this medication, which many of us haven't even used yet in clinical practice because it is new, is that it's not an antipsychotic.
And the name?
The brand name is Auvelity or Auvelity, but it's a combination of two generic drugs that have been around for a very long time that we know a lot about. Those two medications are bupropion, which is otherwise known as Wellbutrin. It's an antidepressant. It's approved for depression. It's approved for smoking cessation. It's been on the market for decades. So this medication is combined with another drug, which is called dextromethorphan. Dextromethorphan is the active ingredient in cough syrup. And the reason why the combination is used is because the Wellbutrin, the bupropion, inhibits the breakdown of the dextromethorphan. If you just took cough syrup, that dextromethorphan gets broken down into a metabolite that's not good for your brain. But if you inhibit it with the bupropion, it stays as dextromethorphan and it does some very interesting things in your brain to certain neurotransmitters that we think are responsible for treating agitation. So that combo was shown in clinical trials to reduce agitation and Alzheimer's disease without the risk and the worry of the mortality thing or the stroke risk, and it doesn't have the motor symptom side effects of the antipsychotics. What we don't really know is how it will work in clinical practice. My gut feeling, just knowing how it works and what I've seen in the research without having used it yet in these patients, is that it won't work as quickly because it's not inherently sedating, which on the one hand is a really good thing, right? We don't want to over sedate people. But we also know that the effect on agitation is not going to happen in a day or two. We're going to have to give it some time. So the relative severity of the agitation may dictate which medicine to use in what situation.
Colleen from Ottawa asked, what are the safest drugs to use daily long term for frequent verbally aggressive agitation? Is that an answerable question?
Well, wouldn't it be nice if we had a different targeted medication for each one of these many symptoms we talked about? Well, so that doesn't occur, right? So when I think about verbal agitation that's frequent, I'll just say and empathize that that may be one of the more challenging symptoms because although physical agitation and depression and anxiety and paranoia often do respond really well. Sometimes verbal agitation, I don't know why. I'm not sure if the data supports it, but my own clinical experience is that's tricky. I'll just reemphasize something we talked a lot about earlier, which is making sure we understand the cause of that verbal agitation, because that still is the key thing. But if we're going to choose a medication for a symptom like this that's common and recurrent, then I think it's really important that we find a medication that's going to be tolerable that someone can take for a while. The antipsychotics generally are recommended for shorter term treatment because of side effect risks. So, medicines like the SSRIs, so the citalopram, which is an SSRI, serotonin reuptake inhibitor, this is a medication that was studied in a National Institute of Aging funded study called CyTAD, and Celexa is the brand name. People are probably familiar with that. It's used for depression all the time. But that study demonstrated that a certain dose of Celexa, citalopram, is effective for agitation of all kinds, including verbal agitation. I think of the SSRIs as being first line treatment for agitation like this that's common, that's prevalent, that's causing distress, but is not an acute safety concern. Like the verbal agitation is going to upset more people around them than the person with the symptom. And so if you've got somebody who's physically aggressive and you need to calm them down now, citalopram is not going to do that. But if you've got verbal agitation or worry or pacing, things that are not imminently dangerous, an SSRI like citalopram is not a bad idea as a first line treatment.
So we have the antipsychotics, you have the Auvelity, I don't know what class that is, and then SSRIs as the drugs that are available with the Auvelity most recently approved specifically for this condition, which is wonderful. Somebody wrote in Ronald from Kirkwood, Missouri, is ECT still used for severe agitation? And I mentioned this to you before, and you said, this is really interesting, bring it up. So I'm bringing it up.
All right, so I'll make a long story short. I love the question. I'm a geriatric psychiatrist, and in my career, I've seen patients' lives saved by receiving ECT for major depressive disorder, severe depression with paranoia and psychosis, and not eating and drinking and wanting to die. And they're a new person within weeks. And with periodic ECT thereafter and medication treatment and psychotherapy, their lives are just transformed. It's the most effective treatment we have for severe recurrent major depression, and it's indicated by the FDA for this. It's not for mild agitation, okay? It's not for people with easy to treat agitation that comes and goes. The people in our study failed 3 medications already. They had severe agitation on one of those rating scales I mentioned. And for the most part, their cognitive impairment was severe. They were receiving ECT. I would call this a palliative intervention. In many ways, a lot of these treatments we talked about today, even the 2 that are approved, are palliative interventions. They're used to improve quality of life. They don't extend life, they don't cure anything. They improve quality of life and symptoms, not just for the person with the illness, but for those around them, including their loved ones.
Manmohan from Clive, Indiana asked, are there any pending medications that are nearer to approval or showing efficacy in phase 3 for agitation? Is there anything else we should be looking for and watching for at this time?
There are a number of trials going on right now in phase 3 for compounds that are trying to either for the psychosis of Alzheimer's or agitation in Alzheimer's, they're trying to get other indications. We're involved with 2 of those, lumateperone, which is a medication that's on the market for psychiatric conditions, is being studied for these conditions, as well as a medication that's called CAR with a K, CAR XT, which is it's the same drug. It's just using a different name for a medication approved for schizophrenia called Cobenfy. So lumateperone is an antipsychotic, but this other drug, CAR XT, is actually a combination of a cholinergic agonist drug called xanomeline, which has been studied for decades for Alzheimer's disease to try treat the cognitive and functional decline, but it caused too many side effects of nausea and vomiting and other, peripheral side effects. So it's combined with an anticholinergic drug that blocks the nausea and vomiting called trospium. So
Right.
that's a combo drug, CAR XT, lumateperone. Those are two that are in phase 3, and there are others. Now there's more activity in this area, which is wonderful. I would love to see a company really put resources behind studying cannabinoids because I think there's a real opportunity for efficacy and safety there. And we just, again, like I mentioned our work, but it's really early days there. I just want to emphasize that the most important thing, if you have a loved one with agitation and aggression, number one is safety. Safety for you and for them. And sometimes to assure safety, we do things that are difficult. We may have to call the police, right? We may have to leave the situation. We may have to think about intervening with treatments that may sedate them for hours to a day because we just need to get control. That does happen. And that's okay as long as we look for why, right? We still have to look for the why. Once the acute aggression is better, and the situation is safe, then we still need to figure out, well, why did this happen? Because we can't let that happen again. And you should not feel like you're out on an island doing this on your own because you can't. I tried to do that for both my dad, who just passed away, and my mom, who's now struggling, because I'm an expert. So I figured, well, I know what to do, but I'm not their doctor. I'm their son. And I would just encourage all of you to make sure that you have the right clinical guidance for these situations because they're really, really hard. Tom Harrison and I published a book a few years ago called The Complete Family Guide to Dementia, published by Guilford Press. I think it came out in 2022. Tom is a law journalist who had a mom with dementia, and I'm an expert in the field. And we wrote this book to really help you as a care partner throughout all phases of the illness, from diagnosis to end stage illness. And there's a big part of that book that talks about how to understand, how to manage, how to deal with, how to get help for these challenging behavioral symptoms like agitation. So I would encourage you to take a look at that. We had some resources in there as well as to where to turn for answers.
So I'm going to read both of these people's question because I get this all the time. I've heard it answered badly, so I'm going to let you answer it wonderfully. Arthur in the chat wrote, I once was told that an Alzheimer's patient's personality, agitation, aggression, um, is a magnified reflection of how they were in earlier life. Is that true? And the one I received in writing was from Mandy in Attleboro, Massachusetts. Is there any correlation between the personality a person has always had and the personality changes they might have with Alzheimer's? For example, an unpleasant person is more likely to become more unpleasant than a person who has always been a delight to be married to. So, the way I've heard it asked in the past is when someone gets dementia and has neuropsychiatric symptoms, is this like exposing their true personality? And I'd love for you to answer that.
Well, the way I would answer that wonderful question is the following. Number one, I don't think I've seen a study that's truly tried to answer that question. It'd be very hard to do that study, right? Now, as a clinician, I would say that more often than not, there's no direct relationship. I have seen plenty people who have told me that their mom was the most difficult, that they had the most challenging relationship, and they were so hard to be around. And now, in the setting of dementia, she's lovable, she's caring, she asks thoughtful questions, she's just a new person. And I've seen the opposite too, where people who are just salt of the earth, amazing parents or spouses unfortunately are now experiencing these symptoms that we just described, and they're hard to be around. That is not willful behavior that says anything about you as a person and as a care partner. That's the most important thing to remember. This disease takes over someone's brain, right? And who we are comes from our brains, right? The biological substrate in our brain in ways that we really don't understand, whether it's chemical or structural. It's all it's all there, right? So personality, behavior, mood, anxiety, all of those different constructs that we understand are changed by an illness that's causing a disruption in brain circuits, in brain cell function. It causes brain cell death, and it attacks different parts of the brain in different people at different times. And so one of the things that I often leave people with is, if you've seen one person with dementia, you've seen one person with dementia, because this illness is different in everybody. And it may be that a pre-existing personality will be happening. You'll see more of it when someone has dementia, but you also may not. So I don't think you can predict it, unfortunately, or fortunately.
Thank you for listening to Let's Talk Alzheimer's. We hope this conversation gave you hope and a better understanding of what is really behind Alzheimer's agitation, why it happens, and some things you can do, hopefully, to modify its effect. Dr. Forrester walked us through some of the causes, from UTIs to medication changes to just the disease itself. And he discussed some of the treatments available today, from lifestyle interventions and music therapy to newly approved medications like Auvelity. And most importantly, he reminded us that agitation is not a reflection of who somebody truly is. This is the disease talking. This is not the person that you love. If you'd like to learn more about Alzheimer's clinical trials or find studies recruiting in your area, please visit the Alzheimer's Disease Research Program at brightfocus.org. And remember, life is very, very short. Tell everyone you love how much you love them. Give them a hug. Hold them close to you while you can. Have a great day. We will see you soon, and be well.
Thanks for listening to Let's Talk Alzheimer's. If this episode helped you better understand Alzheimer's disease, please hit like and subscribe to stay informed. And if this podcast would be helpful to people you know, please share it with them. For trusted information on Alzheimer's and the latest research towards a cure, visit brightfocus.org. Get the latest information on new medications, lifestyle changes, active clinical trials, and breakthrough technologies. Thank you to our sponsors, Lilly, Biogen, Eisai, and Genentech, for making this program possible. And thank you so much for spending this time with us.
Resonate.